I'll be talking to you about recurrent pregnancy loss. First of all, let's go through the definition. Well, a spontaneous loss of pregnancy before the fetus reaches viability includes all pregnancies from the time of conception until 24 weeks of gestation. So hence, it even includes the biochemical pregnancies. Now, coming to recurrent losses, a loss of 3 or more consecutive pregnancies is estimated to be seen in 1 or 3% of women. There are many proposed causes. Most importantly, or rather unfortunately, more than 50%, the cause is unknown. There are many risk factors that have been spoken about. Firstly is the maternal age or the number of previous miscarriages. Are the two independent risk factors for further miscarriage. And the major underlying cause would be an embryonic aneuploidy. Now, regarding maternal age, it's associated with two important things. One, there's a decline in number and decline in the quality of the remaining oocytes. Hence, the risk tends to increase with age. And from here, you can see that the younger you are, the lower chances of miscarriage. The older, above 40, more than 50% patients end up with a miscarriage. So the longer the wait, the more miscarriages they tend to have. Like this, the risk of further miscarriage increases after each successive pregnancy loss, reaching approximately 40% after 3 consecutive losses. And unfortunately, again, the prognosis tends to worse with increasing maternal age. The other issues which predispose to this, for example, maternal cigarette smoking or excessive caffeine consumption and heavy alcohol consumption, these tend to have a dose-dependent effect. The other thing will be female obesity. It's linked to increased miscarriage rates, but it's probably due to the other effects of obesity, other endocrine problems which are associated with it, which I'll be discussing later. The first problem here is the antiphospholipid syndrome. Thankfully, there is a treatable cause in most of the cases. And this refers to the association between the antiphospholipid antibodies and an adverse pregnancy outcome. So there are 3 main antibodies, which is a lupus anticoagulant, anti-karyotiping antibodies, anti-B2 glycoprotein 1 antibodies. And the adverse outcomes include 3 or more consecutive miscarriages before 10 weeks gestation, 1 or more morphologically normal fetal losses after 10 weeks, finally 1 or more preterm births before the 34th. Now, the incidence is said to be 15% of all women with recurrent miscarriage. If we do not treat them, their chances of having a live birth is as low as 10%. So it's important that any patient who has a recurrent miscarriage, they be screened before the subsequent pregnancy. So you need 2 positive tests within 12 weeks apart, moderate to high titer. So you should consider treating them with low-dose aspirin, preferably started prior to pregnancy till the 34th week of the pregnancy. And secondly, will be heparin. There are 2 main types of heparin that we currently use. One is the unfractionated 2 times a day from the positive pregnancy test till 6 weeks postpartum, or a low molecular weight heparin, which can be given on a daily basis. A meta-analysis of randomized trials examine these types of treatments, aspirin, steroids, globulins, and heparins, and in the aim to improve the outcome. So what they found was the live birth rate increases tremendously with aspirin plus heparin, and the treatment combination reduced the miscarriage rate by 54%. And then they also spoke about 2 studies found that if you use low molecular weight heparin in combination with aspirin and even with unfractionated heparin with aspirin, they found that there was no difference with the outcome. The side effects, a lot of patients are always worried about side effects, so are doctors. So aspirin has been tested before in our previous studies where the prevention of preeclampsia and pregnancy, there was no adverse fetal outcome. Heparin, on the other hand, does not cross the placenta, hence there was no problems with the babies. But unfractionated heparin, on the other hand, had certain maternal complications, for example, bleeding, hypersensory reactions, thrombocytopenia, even osteopenia. And that was not seen very much in the low molecular weight heparin. It's definitely a better and safer option. The next issue would be the genetic factors. This affects 2 to 5% of couples having a recurrent miscarriage. Either one of the partners will have certain structural abnormalities, either a balanced reciprocal or a Robertsonian translocation. Now, their pregnancies are increasing. They have risk of miscarriage. However, if they have a live birth, then there will be a multiple congenital malformations, even mental disabilities in these babies. And the effect will depend on the size of the genetic content, which is abnormal. The next issue will be the embryonic chromosomal abnormalities. These abnormalities, the embryo account for 30 to 57% of further miscarriages. So the risk of miscarriages resulting from this increases with advancing age again. So we can do a karyotyping, a cytogenetic analysis of the products of conception, and also parental blood. This will help us to inform the patients regarding the prognosis of their future pregnancies. And we should liaise closely with the clinical geneticists when we do this. As for reproductive options for these patients, you can allow them to get pregnant naturally, and subsequently you can do a certain prenatal diagnostic test, or even gamete donation, and proceeding with other forms of IUI or IVF, or the last scenario, adoption. Now coming to PGT. This is mainly used to rule out certain genetic abnormalities and mainly aneuploidies. The rationale here is for us to identify the best embryo, which is thought to be genetically normal, which can eventually lead to a live birth. But the problem here is that we have to be aware of the financial implications and also the implantation at live birth rates, which, as we mentioned, can be much lower after the maternal age increases. The other factors that they look into is anatomical factors, where certain studies have shown that the prevalence ranges between 1.8 to 37.6%. So it's been noted that if you have arcuate uterus, the risk of miscarriages increases in second trimester. If you have a septate uterus, then you might miscarry in the first trimester. When we have these anatomical problems, the initial assessment is the 2D ultrasound scanning, either with HSG or sonography, which can be done in our clinic. And as for complex malformation, or if you need a definitive diagnosis, then an endoscopic test would be required, like hysteroscopy or laparoscopy. If you have a 3D ultrasound, would be good. And most of the time, I end up doing the MRI because it's non-invasive and you get very clear pictures and you can get your diagnosis almost immediately. As for the uterine septum, this is the commonest malformation. It's seen in about 5% of patients. And it's been known that resection lowers the miscarriage rates. There are two ways of doing it. One is open uterine surgeries, but that case you have a huge uterine scar and you may rupture during pregnancy. And hysteroscopically, they have analyzed 14 studies. They had 1,324 women. The risk with it, perforation 1.1%, laceration 0.1%. As you can see, it's a better and safer option compared to laparotomy. The other two studies we spoke about resection of septal defects. 310 patients reduced miscarriages 41.7% to 11.9. Another one is 361 patients reduced miscarriage from 94.3 to 16.1%. So live birth rate increased 2.4 to 75%. So it's an important thing to treat. The other thing would be fibroids, especially those cavity distorting lesions, should be resected, preferably hysteroscopically, and that will reduce your miscarriage rates and increase your live birth rate by about 50%. The next issue that we tend to face in the second trimester is cycle weakness, also known as insufficiency or incompetence. The bad thing about this is that there are no satisfactory objective tests that we can identify a woman's cycle weakness in the non-pregnant state. We used to think that trying to insert a certain hair gas dilator to assess that which one can go in, but all those things have not been proven to be. The diagnosis is usually, based on history of a second trimester miscarriage, preceded with the spontaneous rupture membranes or painless cervical dilation. So we should screen these women. Okay, if the cervical length is less than 2.5 before 24 weeks, then you may have to do a cervical cerclage. A short cervical cerclage on a vaginal scan during pregnancy may be useful to predict the preterm birth in these cases. So as you can see, this meta-analysis, this from 4 randomized controlled trials reported that a subgroup of women with singleton pregnancies and short cervix, less than 2.5 centimeters, who underwent a cerclage, reduced the incidence of preterm birth before 35 weeks of gestation. So it was beneficial. But as in all surgical procedures, it is associated with certain risk. related to surgery, bleeding, infection, also anesthetic risk, and the risk of stimulating uterine contractions. And the worst risk of all is accidentally puncturing the amniotic sac. There's a small reduction in deliveries before 33 weeks in gestation, which was noted in the study. But the benefit was most marked in women with 3 or more second trimester miscarriages or preterm births. The other access for our cervical cerclage is transabdominal, but it should be done in selected women, especially those with previous failed transvaginal cerclage and or those with short or scarred cervix. That may be beneficial to them. There was a study which compared abdominal with vaginal cerclage, women with failed vaginal cerclage in previous pregnancy. This review concluded that the abdominal cerclage may lower the risk of perinatal death or delivery before 24 weeks, but at high risk of operative complications, bleeding, infections. So whether or not to perform an abdominal cerclage or cervical cerclage, well, remains uncertain. And the newest modality we have is the Arabin pessary, which is even less invasive. The next issue that can cause multiple miscarriages or pregnancy losses will be thyroid and diabetes. Diabetes and thyroid have to be monitored and have to be controlled before they get pregnant. Women with higher HbA1c has increased risk of miscarriages and worse still, fetal malformation. But if it's controlled, both your thyroid and diabetes, then the risk does not increase. There's another subgroup, the subclinical hypothyroidism, especially with presence of autoantibodies. Some clinicians believe that these patients should be treated with very low dose thyroxine, but generally the evidence is very weak. Whatever it is, since it's a medical illness, we should have a multidisciplinary team approach. The next is our favorite progesterone that we always give our patients after an IUI or IVF, hoping that will increase our implantation rates and our pregnancy rates and maintain the pregnancy. So there are a lot of benefits of giving progesterone. One is in the immune response. It creates a more favorable anti-inflammatory cytokine response. And but unfortunately, in the large study, which came on in a New England Journal of Medicine, the PROMISE trial, they used progesterone for recurrent miscarriages. There were 836 patients with idiopathic cause. They had administered uterogastrin 400 milligrams 2 times a day, from the positive test till 12 weeks of pregnancy. There was no difference in miscarriage or live birth rates. However, in a meta-analysis of 10, including the PROMISE trial, they examined the natural and synthetic, and they found that 8 studies found that there was a lower miscarriage when they used the synthetic progesterones rather than the natural progesterones. The other treatment options like giving HCG, well, the evidence was not very strong. As for polycystic ovarian syndrome, it has been linked that to increase miscarriage risk in patients, but how? It remains rather unclear. But mostly due to the, feel that it's probably due to the insulin resistance, hyperinsulinemia, and hyperandrogenemia. Weight loss has definitely been advised for these patients. Okay, and also a reduction in the sugar in the diet, the carbs. And next would be the metformin. Metformin just helps them to use up the sugar more efficiently and reduces the insulin resistance. But the evidence on it is not very strong also. But there's some uncontrolled small studies have shown that use of metformin during pregnancy is associated with reduction in miscarriage in women with recurrent miscarriages and PCOS. But there's no randomized controlled trials to assess this with recurrent miscarriages. The next will be immune factors. HLA incompatibility, no clear evidence. Blood natural killer cells, no clear evidence. So certain clinicians do test the peripheral blood natural killer cells. And they feel that it's a surrogate marker for events that occur in the womb. Unfortunately, evidence showing this correlation is not very strong. From a Cochrane systemic review, they have checked various types of treatment, paternal cell immunization, third-party donor leukocytes, thromboblast membranes, and even immunoglobulins. They found there were no significant benefits. The other thing would be intralipid. A lot of centers have started to use it, but there's no clear evidence that it actually works. The other thing would be a granulocyte colony stimulating factor. That too, unfortunately, nothing works. There are many immunotherapies that people have come up with, but unfortunately, most of them should not be offered routinely, and more studies are required. Now, coming to our infective agents, we've been taught that the torture screening is something important, that all patients should be checked for all these toxoplasmosis, rubella, cytomegalovirus, herpes, diphtheria. But unfortunately, they do not persist in women, and it can be treated. And any severe infection which leads to bacteremia and septicemia, those can cause miscarriage, but whether it occurs in one lady's all her pregnancies and eventually causes a recurrent miscarriage, it's unclear. So the problem is that an infection must be capable of persisting in the genital tract and avoid detection, and also should not cause a sufficient symptom to disturb the woman. So it's difficult to blame these infections to cause recurrent miscarriages. Hence, screening should be abandoned. However, bacterial vaginosis, on the other hand, if detected in the first trimester, has been reported to increase the risk of a second trimester miscarriage and preterm delivery. There's a study where they have given oral clindamycin, and they've noted that it significantly reduced the risk of their second trimester miscarriage and preterm birth. But unfortunately, there are no published data to assess the role of antibiotics in previous second trimester miscarriages or losses. And also, what antibiotic and how long would you want to give it? Next, the inherited thrombophilia, which includes this list of things: activated protein C resistance, factor V laden, antitropin 3. All these things are established cause of systemic thrombosis, and it's been shown that it causes recurrent miscarriages. However, treatment options, we generally believe that giving low molecular heparin may help these patients to improve their live birth rates. There's a study, a LIVE-2 study, which wants to evaluate the efficacy of low molecular weight heparin in women with inherited thrombophilia and recurrent miscarriage, with the live birth as the primary outcome. I don't think the study has been completed yet because I tried searching it online. Let's hope to get more clarity once this study is out. There's one prospective randomized trial demonstrated that the efficacy of low molecular weight heparin for treatment of women with history of miscarriage after 10 weeks who carry the factor V laden. Okay, the live birth rate increased with enoxaparin 86% compared to 29% women taking aspirin. So probably, well, low molecular weight heparin is the way to go in these patients. The next, the unfortunate group of patients which we do not know why they are miscarriaging. They have an excellent prognosis for future pregnancies without any treatment. They just need tender, loving care, supportive care. No matter what we do, all the investigations, all will come out all as normal. And the prognosis for successful pregnancy in future, just with supportive care alone, healthy lifestyle, okay, it's about 75%. But the prognosis worsens with maternal age and the increase in number of previous pregnancies. There were two studies which I found, which were published in 2010, where they had treated these patients with aspirin alone or in combination with heparin. Well, they didn't find any improvement in live birth rate. So in summary, if you have anti-phospholipid syndrome, you want to use heparin with low dose aspirin, as it definitely helps. If you have uterine septum, resect it hysteroscopically, similar with fibroids, polyps, and even adhesions inside. Those with chromosomal abnormalities, you might send them for genetic counseling or even gamete donation, subsequently IVF or even intrauterine insemination. You have a thyroid disorder, treating with thyroxine, but in subclinical cases with anti-thyroid antibodies, you may want to treat them with low-dose thyroxine. And unexplained, as I mentioned, you can, there's not much of treatment there. Probably you can treat them with some progesterone, and it may be beneficial in some patients. Psychological support, tender loving care in a proper clinic for the patients with recurrent miscarriages, well, will be necessary. Thank you.